Next slide. So this is the first webinar of a monthly series. We will be holding these webinars on the last Tuesday of each month at this time, and we hope as many of you can join us as possible. They will be about 60 minutes, 45 minutes to 60 minutes each. And the previous webinar series and all recordings will be posted on the webinar series page. So please be sure to access that resource for any webinars that you may have missed. Next slide. So I'm very pleased to introduce the moderator for today's session, Dr. Abdulrahman Jazieh, who is the chairman of the Department of Oncology at the King Abdulaziz Medical City in Riyadh, Saudi Arabia. Over to you, Dr. Jazieh.
Well, thank you, Doug. Hello, everyone. I'm very excited to have you all in this webinar, which is a continuation of what we started before the annual meeting. The difference is that it's going to be a monthly webinar in the last Tuesday of each month. The theme of today's webinar is learning through collaboration. It shows us, the presentation will demonstrate to us the importance of large-scale collaboration in facing COVID-19. So without any delay, I will go ahead and start with the introducing of the speakers. Just a note for our audience that we will have the 3 presentations in a row, and then we'll have the question-answer session in the end. So please feel free to post your questions in the QA platform so we can answer them in the end. I will introduce the speakers briefly, and if you need further details about their credentials and accomplishment achievements, you can find it in the website. So we'll start with the first presentation. It's my distinct pleasure to welcome and introduce Dr. Jeremy Warner, who is an Associate Professor of Medicine and Biomedical Informatics at Vanderbilt University. And he is the Associate Editor of JCO Clinical Cancer Informatics and Deputy Editor of hemonc.org. His talk will be about the COVID-19 and Cancer Consortium. Jeremy, all yours.
Thanks very much. You can go to the next slide. So I'm going to give you a brief overview of the COVID-19 and Cancer Consortium, which we call CCC-19 for short. This is a very young consortium. We've been around for just over 3 months now. And it really started with a tweet, really a social media phenomenon from a resident. It's actually his last day of residency is today, Dr. Jazieh. He's starting hemonc fellowship at the Mayo Clinic tomorrow. So really looking forward to welcoming him to the hematology oncology community. But even before that, he sort of set off this chain of events, which led to this consortium of now over 100 sites and a website, a Twitter account, over 1,300 followers. And you can see some references here to some of the founding information. Next slide. So early on, we created a mission statement, and really, to sum it up, the idea was to rapidly gather information about patients with COVID-19 and cancer and disseminate the results as quickly as possible. Next slide. This is an interesting biography, if you will, of the COVID-19 and Cancer Consortium that was published in Medscape last week. I encourage you to read it. I know this is a global webinar. I'll just mention, as you can see from the introduction here, this, while our members are primarily US-based, we really have a global reach. And part of how we got started was reaching out to an organization that had the website in their possession at that time, the Findhorn Foundation. And it's an interesting but short story about how we ended up from their generosity getting the website and really launching our efforts. Next slide. So this is where we're at today. We have 114 participating institutions, mostly in the US, some are in Canada. Many of these are NCI designated comprehensive cancer centers. We also have a distinct number of organizations that are in the corp community or minority and underserved practices. And so we think we're getting a fairly representative view, at least across the U.S., of the academic medical centers and some community practices as well. Next slide. So we started slow but rapidly picked up in terms of the number of cases that were being reported. And what I'm about to share with you is the data from our first data lock, where we had already had over 1,000 cases submitted to the central database of CCC19. As you can see, we've continued to accrue cases after that, and we're actually now approaching 3,000 cases as of our latest data lock, which was last Friday. Next slide. So here is the consort diagram from our first publication describing our early results. So again, we had over 1,000 cases. Some of these were excluded as they were in situ carcinoma or other ineligible cancers. Our primary reason for exclusion for this first analysis was patients who did not have laboratory confirmed COVID-19, which is a small number, and we've actually continued to see that our rate of laboratory confirmed cases is over 90%. So in this first analysis, we looked at 928 cases. Next slide. Here are some characteristics described from our paper. There are just a few. We looked at many others, including age, race, ethnicity, and so forth. But these are the cancer-specific characteristics. So just under half of our population was in remission, and the other half had a cancer that was present, mostly stable or responding, and about 10% with progressive disease at the time of their COVID-19 diagnosis. Most patients had an ECOG performance status of 0 or 1. And then on the right, you can see that about more than half were not actively receiving anti-cancer therapy, which we defined as being within 4 weeks of the COVID-19 diagnosis. Of those that were receiving therapy, it was split about 50-50 between non-cytotoxic therapies and cytotoxic chemotherapy. Next slide. So these are our rates of complications, and this is similar to what I presented at ASCO, but with updated numbers based on additional follow-up through our latest data lock of June 26th. We initially described 121 deaths. That's increased slightly. The percentage for this particular cohort still remains at 13%. And you can see the other complications listed there. Of note, more than half of these patients end up hospitalized, close to 60%. Next slide. When we look at mortality for select subgroups, we saw a wide spectrum. And I'm not going to go over every number on this slide, but if you look at the top, we saw that patients who had an ECOG performance status of 0 and no comorbidities had no deaths in this particular cohort. Whereas if you look at towards the bottom, we see that the older patients, so those over the age of 75, as well as those with the ECOG performance status of 2 or higher, do very poorly in the setting of mechanical ventilation with mortalities in excess of 50%. Next slide. We also see differences when we look at specific subtypes of cancers. And again, you can see a range here. At the top, you see that thyroid cancer, at least with these relatively small numbers, had no deaths out of 23 patients. Breast cancer resembled more or less the population averages at 6%, or about half what we were seeing in the overall cohort. And then towards the higher ends there, you can see lung cancer as well as lymphoma had mortalities around 20%, and you'll hear from the Terraville folks that they saw even higher mortalities than that for lung cancer. Next slide. So this was our logistic regression model where we looked for select factors that were independently associated with 30-day all-cause mortality. And what we found was that older age with an increasing risk per decade of nearly twofold, as well as male sex, being a former smoker, having an ECOG performance status of 2 or higher, and having a cancer that was present were all independently associated with an increased mortality, with the highest associated risks being in those populations with an ECOG of 3 or higher and progressive cancer. Next slide, please. Perhaps just as importantly, we found that certain other factors, clinical variables that we looked at did not reach statistical significance. And I have to caution about these results because our numbers were relatively small, and we might find that some of these change as we accumulate more data with longer follow-up. But in this initial analysis, we did find that race and ethnicity did not appear to be associated with mortality independently, neither did obesity or cancer type, or whether the patient had been receiving chemotherapy or other therapies within the 4 weeks prior to COVID-19. And next slide. So like I mentioned earlier, we are now approaching 3,000 patients, which is about 3 times as much as we had in that initial analysis. And we are currently not only repeating the initial analyses, but we're also starting to make a deeper investigation into some of the possible COVID-19 treatments and how they might affect outcomes. And these include hydroxychloroquine, antivirals such as remdesivir, anticoagulants. We also have active sub-projects looking at geriatric populations. I didn't mention this earlier, but 30% of our cohort is over the age of 75. We're also having specific projects looking at prostate cancer and other GU cancers, as well as immunotherapy. And we're actively seeking to expand to Mexico and the rest of Latin America currently. If you have questions or want to learn more, please visit our website. I will note that right now we're having some glitches. If ccc19.org doesn't work, please use ccc19us.org, and that will work for now. We're working on getting it fixed. So with that, I'll pause and thank you very much, and I'll take questions at the end.
Well, thank you, Dr. Warner, for sharing this interesting data and update from ASCO presentation. So without further delay, I will move on to the second presentation. It's my pleasure to introduce Dr. Leora Horn, who is an Ingram Associate Professor of Cancer Research and Associate Professor of Medicine, and Assistant Vice Chair of Faculty Development at Vanderbilt University Medical Center. She'll be talking to us about COVID-19 and cancer, a new perspective on cancer care. Dr. Horn?
Thank you, and thank you for having me here this morning. Next slide, please. So we're facing a dilemma with COVID-19, and really we're looking at this from the side of the patient. You know, thinking about, does age matter? As Dr. Warner showed us, does cancer type matter? Do comorbidities matter? Does the treatment this patient's facing matter? How does therapy to treat COVID-19 matter? And how does access to care matter? Next slide, please. So we know that there's this clinical dilemma when we think about patients with lung cancer and COVID-19. Common presenting symptoms are dyspnea, cough, fever, anosmia, fatigue, and these are also very common presenting symptoms that we see in our lung cancer patients. It's also, on the next slide, a radiographic dilemma when we look at our patients because on the right-hand side, you see a patient who has SARS-CoV-2 pneumonitis, and on the left-hand side, we see a patient with immunotherapy-induced pneumonitis. And I have had many calls over the last few months from our radiologists for patients having routine scans saying this patient has pneumonitis. I can't tell if it's SARS-CoV-2 related or if it's related to their checkpoint inhibitor therapy. Next slide, please. So what we have also seen prior to some of these large data sets coming out specifically on cancer patients with small data sets, primarily out of Asia, where the virus first emerged, and what we found that the pooled prevalence in these data sets was around 2% of patients. We saw that patients with cancer and cancer survivors were an important at-risk population for COVID-19 and mortality from COVID-19, and we also saw that patients with lung cancer were thought to be particularly at risk. Next slide, please. And so the TerraVault Consortium was formed. This is the Thoracic Cancers International COVID-19 Collaboration. It's a registry for patients with thoracic malignancies, and similar to how Dr. Warner's consortium started, this started with an email idea from Dr. Marina Garasino from Milan, Italy, that was particularly hard hit by COVID-19. She sent it out to around 50 medical oncologists who specialize in thoracic cancers around the world, and I really think it's a testimony to what happens when people come together for our patients and our care. Within 1 week, we had a final protocol approved, we had an ECRF developed, and we had IRB approval both at Vanderbilt University Medical Center and in Milan. The data that we presented at ASCO this year was the cutoff of the first 400 patients with complete data that was entered into the ECRF, and there is also a publication in Lancet Oncology on data from the first 200 patients that were presented by Dr. Garasino earlier this year at AACR. Next slide, please. The consortium goals are simple. We want to determine the demographic factors, comorbidity, and cancer characteristics that patients with thoracic malignancies who develop COVID-19 most at risk for hospitalization and death, understanding the clinical course of patients with thoracic malignancies, which is maybe slightly different from other tumor types, give practitioners in our consortium real-time data on therapeutic strategies that may impact survival, evaluate the long-term impact on cancer outcomes related to care adjustments and delays in care with patients with thoracic malignancies. It's a fluid database, so as data on COVID-19 evolves, we've adapted and increased the number of data points in our database. Next slide, please. Different from CCC19, the inclusion criteria are that patients either have a laboratory-confirmed COVID-19 test, or they may have a suspected case clinically based on symptoms and a known exposure to a patient who's confirmed COVID-19, or they may have radiographic symptoms with lung imaging features consistent with coronavirus pneumonia, along with symptoms of coronavirus pneumonia. Local IRB approval is required prior to data entry in the RevCap database. We've had interest expressed from just over 200 cancer centers globally. We have IRB approval now at almost 100 cancer centers, including all 5 continents. Next slide, please. The data that we found, the baseline demographics were really divided into 3 different cohorts. Those patients who had recovered from their infections, those patients who had died as a result of COVID-19, and those patients with ongoing infection. We can see specifically, if we focus on the patients who had died, that those patients were slightly older. There were more patients who had an ECOG performance status of 1 or 2. There was a slight difference in those patients being on anticoagulations or steroids, not to treat their COVID-19, but prior to the COVID-19 diagnosis. And there was no real difference in the number of lines of therapies that patients had been administered. Next slide, please. When we look at the comorbidities of these patients, we see that, again, if we focus on those patients who had died, that those patients who had died were more likely not to have any comorbidities, with 31% of patients having 1 or 2 comorbidities. The most common comorbidities that we saw in these patients were hypertension, COPD, diabetes, vascular disease, as well as renal insufficiency. Next slide, please. When we look at the therapies that these patients were on at the survival of these patients as a result of their comorbidities or even therapies that these patients were on, we can see that age over 65, the presence of any comorbidity, not a specific comorbidity, an ECOG performance status of 1 or 2, steroids of more than 10 milligrams, anticoagulation, and cancer therapy within the last 3 months, specifically chemotherapy or chemotherapy in combination with a checkpoint inhibitor, were all associated with increased risk of mortality from COVID-19. Next slide, please. When we looked at the outcomes of patients, we can see that much higher than CC19, there was a 35% mortality. The follow-up in our database was 30 days, which was a little bit longer than what we had with CC19. We can also see that 80% of deaths were due to COVID-19. The ICU admission rate for patients with thoracic malignancies was lower than what we see when we look at the global cancer database. And an analysis of patients who were not admitted to the ICU found that many patients, it was not indicated due to lack of resources or potential physician biases. Next slide, please. When we looked at the multivariate analysis of risk factors associated with death from COVID-19, age over 65, an ECOG performance status of 1, steroids prior to COVID-19, and chemotherapy within the last 3 months, all were associated with increased risk from death from COVID-19. Next slide, please. So when we have also looked at data that's come out from a single institution at Memorial Sloan Kettering, also considering was this a biased database, many of the patients included in our initial analysis were from Europe because that's what was hard hit by the pandemic first, and there's ongoing entry of patients from the U.S. We're in almost 750 patients right now. But in this analysis, they also looked at 69 patients with lung cancer. They also looked at that question of immune checkpoint blockade and how that affected outcome. You can see that here in the U.S., the hospitalization rate was a little bit lower at 63%. The admission to the ICU was a little bit higher at 23%, and the death rate was slightly lower at 24%, not the 35% we saw when we included patients from Europe. They found that male and smoking history were associated with increased mortality, but similar to what we found, the use of checkpoint inhibitor therapy was not associated with increased risk of mortality in lung cancer patients. Next slide, please. So when we think about the patient consideration, does age matter? We think it does. We think that age over 65 years, similar to other data sets looking at the general patient population, age is a risk factor for death. Does cancer type matter? It appears that lung cancer patients are at increased risk compared to what we've seen in CCC19. We also have an analysis that will be presented at AACR later this month, looking at the different types of lung cancer patients, small cell lung cancer, thymic carcinoma, mesothelioma. Comorbidities do appear to matter, but we are not certain at this time which comorbidities in lung cancer patients specifically matter. It appears that the presence of any comorbidity matters. Treatment type appears to matter. The therapy to treat COVID-19 in our analysis did not appear to matter, so whether patients were treated with anticoagulation, steroids, hydroxychloroquine, anti-IL-6 agents, antibiotics, it did not appear to matter, and access to care may be a factor that I think will have better data as our data sets increase. Thank you. When we look at the ASCO guidelines, ASCO has come out with some important guidelines looking at allocation of resources for patients in this, during this pandemic. One of the important things that we should think about that the allocation should be based on maximizing health benefits to the entire population, that we need to consistently and fairly prioritize allocations of resources before the allocations become necessary. So thinking about this ahead of time, which I know we've done a lot here at Vanderbilt University Medical Center, we need to think about decisions regarding these resources should be made separate from the bedside decision-making. It should not be limited to the oncologist making these decisions. We need to consider evidence-based information regarding life expectancy. It was a little bit hard to see that many of our patients in our lung cancer database had either had no therapy or on first-line therapy at the time of their COVID-19 infection and death. All cancer diagnoses and prognosis should be considered individually with input from the individual treating oncologist. We should be better engaged in advanced care planning and discussions with our patients in this era of COVID-19, and hopefully that's a trend that will continue even after this pandemic hopefully passes. Oncologists should communicate their allocation plans with the support of their healthcare institutions. We shouldn't be left there to tell our patients we can't offer them ICU care. It should be done as a larger institutional scale, and we should work with our institutions on how best to use scarce resources during this pandemic. Thank you.
Thank you very much, Dr. Horn, for this nice presentation. As we stated earlier, for our audience, you can post the questions and we'll take the questions at the end of the session. We'll move on now to the third and last presentation of this webinar, and it's about impact of COVID-19 on clinical research and care delivery. It's my pleasure to introduce Dr. Richard Schilsky, who is the Executive Vice President and Chief Medical Officer of the American Society of Clinical Oncology and the Association for Clinical Oncology. Rich, the mic is yours.
Thank you very much, Dr. Jazieh, and good day, everyone. So I'm going to try to talk a little bit about the various ways in which ASCO is trying to learn about the impact of COVID-19, both on care delivery on individual patients, but also its impact on our ability to conduct clinical research during the pandemic. Next slide, please. So this is my agenda. I'll talk briefly about a recently published ASCO survey of research sites. I will describe the ASCO COVID-19 registry that we launched in April. I'll talk a little bit about some insights that we are able to derive from our real-world data platform called CancerLink. And then I'll briefly mention an initiative that ASCO has ongoing right now that we call the Road to Recovery to help us formulate an approach to cancer care delivery and research as we emerge from the pandemic, incorporating the learnings and modifications from our experiences during this time. So next slide, please. So regarding the survey, in March of this year, just as the pandemic was beginning to take hold in the U.S., we recognized that there would be an immediate impact on the ability to conduct clinical trials, particularly at a community setting, but really across the board. So we launched a survey to learn about the challenges and changes to conducting clinical trials early on during the pandemic. We sent the survey to about 65 organizations. We had 32 respondents, 18 community-based practices, 14 academic sites. And not surprisingly, we learned that very quickly it became difficult to enroll patients on clinical trials and became increasingly difficult to maintain strict adherence to the requirements of the clinical trial protocols. On this slide and the next, the numbers in parentheses reflect the percentage of responding sites that provided that particular answer. So as you can see, 55% of the sites had already witnessed a decrease in patients' ability or willingness to come to the site for clinical trial treatment. 50% of the sites began to recognize that it was difficult for them to comply with protocol requirements because at many clinical facilities, other necessary ancillary services had been shut down or diverted to care of COVID-19 patients. So it was difficult to obtain radiology services, surgical services, interventional radiology, cardiology services, and some laboratory services that were necessary to monitor or confirm eligibility for patients on clinical trials. Staff time to organize and implement telehealth visits, which many practices switched to early on, was a challenge. And many of the practices reported to us that they received inefficient, duplicative, and importantly, inconsistent communications from sponsors or the CROs they were working with about the particular clinical trial portfolio at their site. Next slide. What did they do in response to these challenges? 88% of the respondents began to employ telehealth visits for at least a portion of the patients on their clinical trials. Commonly, that was used for patient review of symptoms or monitoring for some adverse events. Many of the sites began to allow their patients to receive care remotely from the clinical trial site, so either seeing a physician closer to home for a clinical exam, having imaging at a facility closer to home, or laboratory testing was all permitted. Importantly, oral drug shipments were diverted to shipments directly to the patient's home, so the patient did not need to come to the clinical trial site to pick up the investigational oral therapy. And some institutions began to implement remote consenting of patients using a telehealth visit in order to accomplish that. Most sites sent their research staff home to work remotely, but in some cases, research staff were actually diverted to clinical responsibilities in order to support the needs of the facility and the care of COVID-19 patients. Site initiation visits and monitoring visits for clinical trials were converted at most places to remote visits. And many sites stopped doing research-only visits and only allowed patients to come for protocol-directed visit if it involved receiving cancer treatment. 60% of sites reported halting or limiting screening for trials, and importantly, prioritizing trial enrollment. So in many places, either the site shut down their clinical trial enrollment or the sponsor shut down their clinical trial enrollment. And sites had to make difficult decisions about which patients and which trials to continue. And typically, they continued those trials that were for patients who were being treated with curative intent or with the goal of prolonging survival, or where the treatment included a therapy that was already an effective established therapy. So typically, phase 3 trials were the ones that continued whenever possible. Next slide. What did we learn from this exercise? And this has all been published in the JLP, so you can look it up if you like. Many of the changes that were implemented actually make trials more patient-friendly and reduce the time and expense participating in clinical trials. So these are things that we may want to carry forward even as we emerge from the impact of the pandemic. Strategies and resources are needed to navigate and adapt, including clearer guidance from FDA or around the world, other regulatory agencies that include specific examples and standard operating procedures that we can incorporate into the way we work. Technology can be leveraged effectively to limit in-person visits and minimize risk to both patients and staff. It is possible to conduct more streamlined, pragmatic clinical trials. Many of the things that many of us have advocated for over many years and thought simply couldn't be done, in fact, were done virtually overnight in response to the pandemic. So clearly, change can be made. We can't assume that all of these changes are going to be successful. We need to continue to assess their impact on patient safety and, importantly, on the scientific integrity of the studies we're doing. We need regulatory and research agencies to support necessary changes. We need buy-in to this from sponsors and CROs. And ultimately, we need to also shift to more pragmatic and streamlined clinical trials that collect the minimum necessary data in order to address the research objectives. Next slide. So I'm going to switch now to talk a little bit about ASCO's COVID-19 registry, which has some similarities but also some differences to both the CCC-19 registry and the Teravolt registry that you've already heard about. Our objectives in launching this were to analyze the distribution of symptoms and the severity of COVID-19 among patients with cancer, to examine the impact of COVID-19 on cancer treatment and outcomes, and importantly, to document adaptations of cancer care delivery due to the pandemic. So this registry is really structured in two ways. There's data being collected about the way in which practices have responded to the registry in the way they organize care, and then there are questions about the impact of COVID-19 on cancer treatment and outcomes for individual patients seen in the practice. Eligible patients are those in active cancer treatment who have a confirmed COVID-19 diagnosis, confirmed meaning test positive. The registry right now is open to all practices in the U.S., and our plan is to issue periodic reports and prepare scientific manuscripts, of course, for publication in peer-reviewed journals, and we will be making data from the registry available as it accumulates for external researchers upon request. Next slide. So this registry launched only on April 10th of this year. We've had about 100 practices around the U.S. that have expressed interest in participating. They do have to execute a data use agreement with ASCO and obtain IRB approval locally, although they can use the IRB determination from our central IRB that this registry actually does not constitute human subjects research, and therefore individual patient consent is not required. 36 practices in 22 states across the U.S. have fully enrolled. They've entered data on more than 100 patients already. And importantly, the registry is structured to hopefully allow us to obtain follow-up information on patients. We are collecting limited identifiable health information that should allow us to link data forms that are coming from the same patient at the same site, and thereby follow patients longitudinally. And we've had more than 100 follow-up forms submitted as the health status of the patients has changed. Next slide. So I don't have any data to present about individual patients yet in the registry, but I will briefly review some of the initial results regarding practice changes that have been reported. So this data is as of June 8th. It represents data from 20 sites that are part of 17 practices located across 15 states. And you can see the distribution of the practice types on the slide. Not surprisingly, of course, 90% of the reporting practices reported new use of telemedicine in managing their patients. 85% conducted some or all routine visits for patients not in active therapy by telemedicine. 15% delayed some routine clinic visits for patients. 60% of the practices were allowing lab collection closer to home. 40% experienced staffing reductions or changes in staffing due to either reassignment of staff to other parts of the institution or hospital, COVID-19 illness among the staff, or simply a desire to reduce scheduling, to reduce staffing due to reduced scheduling of patient visits in the office. We do have an abstract that will present updated data at the upcoming AACR meeting later this month, so stay tuned for that. Next slide. Now, as I mentioned, the registry is open right now to all practices in the United States, although we've had some inquiries from around the world of institutions that are interested in participating. And so our approach right now is to hopefully facilitate the setup of this same REDCap registry at other facilities that are interested in other countries around the world, and then to import data from those other hopefully identical registries into the ASCO database, rather than allowing for patient entry directly into our database. This is due largely to local regulations that vary country by country regarding patient privacy that will actually make it easier for each country to establish their own registry and then export the data to ASCO. We've also been talking with Dr. Warner and Dr. Horn and the leaders of other registries around the country. There's another registry established by the American Society of Hematology for patients with hematological malignancies. There is, of course, also a prospective observational study that's been launched by the National Cancer Institute. So we are certainly open and interested in opportunities for collaboration. We've established a steering committee that will oversee the ASCO registry, along with the activities of our CancerLink data platform as they relate to COVID-19. And we have 2 international participants in the steering committee, Dr. Jazieh, of course, and then Dr. Nancy Baxter, who is Canadian but currently working in Australia. Next slide. And then finally, I'll mention some of the insights observed on the CancerLink platform. So I think many of you are aware that CancerLink is a big data platform. It is collecting the complete electronic health record from participating practices around the United States. There are 25 practices that have been contributing to the data that is displayed on these slides. Overall, CancerLink has about 3 million patients represented in its database. About 1.5 million of those are cancer patients, the others being patients with benign hematology disorders. And so, of course, many of those patients have now experienced COVID-19, and that's reflected in the CancerLink data. All of the slides that I'm showing you here are available and posted on the CancerLink website, so you can explore them in more detail. But you can see in each of these slides the COVID-19 cancer patients are in blue. The non-COVID cancer patient population is in orange. So relatively equally distributed between males and females. On the age distribution, interestingly, you do see the predominance of COVID-19 cases in older patients, of course, but there still are younger patients represented in this data set who have COVID infection. Next slide. Looking at distribution by race and ethnicity, in CancerLink, we're seeing what has been reported elsewhere, which is somewhat of a shift toward overrepresentation of COVID-19 cases in African American and Hispanic individuals. And then on the next slide, you'll see distribution of COVID-19 cases by cancer diagnosis. And of course, keep in mind that in the cancer database, like in many registries that include cancer patients, the most common cancer diagnosis is breast cancer. So there's lots of breast cancer cases, and there's lots of breast cancer patients with COVID-19 represented in the CancerLinQ data set. But interestingly, if you look at the proportion of patients who have hematological malignancies, you'll see that there is a substantially higher prevalence of COVID-19 in patients with lymphoid leukemia, with patients with plasma cell disorders, patients with myeloid leukemia, patients with non-Hodgkin's lymphoma, compared with the prevalence in many of the common solid tumors, where the prevalence is more in line with what the prevalence of the tumor type is in the database overall. So this certainly leads us to believe, and others have reported this, that patients with hematological malignancies at least are at somewhat higher risk of developing COVID-19 infection. Next slide, and then I'll finish up. So I mentioned the ASCO Road to Recovery Steering Group. This is really two task forces in one that aims to assess major impacts of COVID-19 on cancer care delivery, practice health, and clinical research. They are charged to recommend operational and policy strategies to ensure access to high-quality cancer care and sustain progress in clinical cancer research. They will provide recommendations on cancer community preparedness for the future, and they will work with appropriate committees and groups within ASCO to identify additional data and research needs for the future. They are charged to present their recommendations to the ASCO Board of Directors in August, and then following that, there'll be a complete report that will be submitted for publication. So I think that's my last slide. There might be a thank you slide next, but, this is the leadership group of the Road to Recovery Steering Group. I mentioned there are two task forces led respectively by Drs. Nate Pinnell and Melissa Dillman. And with that, I will say thank you for listening, and I'll turn it back to Dr. Jazieh.
Well, thank you, Rich, for this nice overview of the activity from ASCO. So now we'll go ahead and start with the question and answer sessions. And I would like to invite all the participants who have any question to post it in the QA platform. Sorry. So we'll start with the first question to Jeremy, actually. How are the findings of the study, Jeremy, affected your practice? What are the practical tips and things that impacted your practice that our audience from different countries could take home and implement in their practice?
So I think it goes without saying, but it's still worth reiterating. It's really important for patients with cancer to not contract this virus in the first place. And so when we think about how to do that, there's a lot of issues around that. It seems that most transmission of the virus happens in home settings, or actually in our state, 50% of the cases have an unknown source. And so I don't think that patients are necessarily contracting this from healthcare settings, but that has to be considered. And so, one thing, so I primarily work inpatient, and one thing that we've implemented here at Vanderbilt is to screen every single patient being admitted to the hospital. The rates of positive for asymptomatic patients are low, but getting close to 1%. So that's real. And when we think about what to do with those findings, that's a whole nother story. If a patient has a curable cancer and they need high dose inpatient chemotherapy, it really becomes a very morally hazardous situation. But outside of that, I think we have to do what we've been doing all along for our older patients and our patients with poor performance status, or really all our patients, but especially those populations as illustrated by our findings. We need to have advanced care planning in place for every patient. We need to seriously discuss hospice and end-of-life planning at really any stage of cancer diagnosis. It's never too early to think about these ideas and to make sure that patients are informed about them. And then I think we move forward with caution. our findings about recent therapy were somewhat reassuring, and combine that with the finding of low mortality in patients with a excellent performance status and no comorbidities. I think for those populations, proceeding with treatment as planned is something that I would feel comfortable with.
Thank you. Okay, Dr. Horn, if you can elaborate from your standpoint, but there are specific things that I received questions about it that you can clarify, especially, the role of immune therapy that, doesn't increase the risk. One of our audience asked, how do you distinguish between pneumonitis induced by IO or, of COVID-19 pneumonitis? So if you don't mind to reflect on that, and then also how did your study change your practice in real life?
Yeah, so, answering the first question, you can't really distinguish the two based on imaging. You need that test. We're lucky at our institution where that test is normally back on a patient, sometimes within hours if we order a rapid test, realizing that in some cases the test may be negative, but the patient may still have SARS-CoV-2 infection. I think one of the reassuring things that came out of the UK database is that steroids are potentially safe to administer in patients with COVID-19. There's a lot of conflicting data that keeps emerging. There was a paper last week in Lancet suggesting immune checkpoint inhibitors were associated with increased mortality, and unfortunately most of the data that we're getting is from large retrospective series. Lung cancer itself is a pandemic, and so if we stop care or we don't deliver optimal care, the improvements we made when the data came out from the American Cancer Society last year showing improvements in lung cancer mortality are all going to be set back by worsening mortality due to lack of patient screening, lack of access to care, and lack of optimal care for patients. For our patients, we're screening patients prior to them starting on any systemic therapy. We bring patients in a couple days before. We have actually seen in our database that it's not necessarily that infections are happening at home. Some of those infections are coming through contact in the healthcare system. So minimizing your patients' visits. We used to bring patients back a week after starting chemotherapy for a toxicity check as well as lab check. We're now offering patients that they can go into their local pharmacies where they can get their lab draws and offering a telehealth visit instead so that we minimize their back and forth within the healthcare system. Thinking about, for patients who are on some of the therapies where, for example, pembrolizumab has been approved from 3 weeks to 6 weeks, durvalumab in lung cancer after concurrent chemoradiation therapy is technically approved every 2 weeks, but it is FDA approved every 4 weeks for small cell lung cancer patients. And so can you minimize patients' touch point with the healthcare system by using some of the therapies in different ways than what we've traditionally been accustomed to doing?
Okay, thank you very much. We may come back to that later. Coming back to Dr. Schilsky, in old days, it takes like 16, 18 months, 2 years to get the study in cooperative group, and probably up to 10 years to have it published. Now we have studied 10 weeks from the idea to publication. What do you think the impact of the pandemic on research and scholarly work in cancer specifically?
Yeah, it's a great question. I mean, of course, the studies that have been stood up so quickly are observational studies, not intervention studies. So, not to say that we don't need to accelerate the process by which we launch clinical trials. As I mentioned, many of the things that changed almost overnight in the way trials have been conducted during the pandemic are things that we hope can carry forward into the way we do clinical trials in the future. Of course, this is been a longstanding interest of ASCO's. We've done a lot of work over many years now in terms of how to simplify eligibility criteria for clinical trials. We have a whole new set of recommendations that will soon be published about how to further simplify eligibility criteria and also simplify some of the operating characteristics of clinical trials. We have, advocated strongly to simplify adverse event reporting for clinical trials and to streamline the entire process by which clinical trials are develop. We need to remember that many of the things that we find objectionable in the way clinical trials are conducted are things that we as a research community have in fact created. And the good news there is that if we've created them, we can strip them away. And I think we need to focus on what's the patient population of interest and what's the best strategy to enable them to access the clinical trials, as well as what's the minimum necessary data to address the research objectives, and not embellish our clinical trials with various other requirements that make it more difficult for trialists or patients to actively participate in the study. So the future is really to build on the momentum that has been put in place by our need to respond to the pandemic, and to demonstrate that the changes that have been made can be carried forward without threatening the scientific integrity of the trials or without threatening patient safety. And if we can do that, then hopefully that will launch us on a new trajectory that will make it easier, quicker, more efficient, and less expensive to do clinical trials in the future.
Thank you. Thank you very much. So, question back to Jeremy. We learned about, quick question about, is the consortium open for sites outside Latin America? I know you are studying it discussing it with Latin America. Are you open for sites outside? But the other question is, we know a lot about those patients who get admitted and their outcome. Do we know are there criteria how you'll be able to manage COVID positive patient as an outpatient? We need to, because now we may have resources issue, hospital bed issue, and so on. Are we learning, whether from your study or Dr. Horn study, are we learning how to manage oncology patients who are COVID positive as an outpatient? Do we have data? Do we have an idea how we are going to do that? You are muted. Can you unmute yourself, please?
Yeah, okay. Someone did it. Thanks for the question. So, we've actually entered into a collaborative agreement with ESMO, and ESMO has launched their own registry called the ESMO Co-Care, which is available throughout the world. And CCC19 is focusing on North and South America. So that's the answer to that question. But if you're interested, still please reach out to us, and we can connect you with ESMO if needed. As far as the question, I think an unanswered question in all of our studies is what are the longer term outcomes for these affected patients? We've crept up to a median follow-up now of 30 days. It's still very short. And you can imagine that many of those patients still have ongoing infection or complications from the COVID. And we're starting to look at how it's affecting their cancer care after recovery. And I think this is going to be a long process. It's going to take a long time to understand that a little bit more fully. So it won't be another 10 weeks, until we really understand those impacts, including on whether ultimately prognosis is going to shift for the patients so affected, and for all cancer patients, which is a really big concern of the National Cancer Institute, is that we would lose progress on the gains we've made in cancer over the past decades. But in terms of the specific patient, I would say it's very variable, and Dr. Horn probably can speak more to this, but I would say that each institution has its own approach. I doubt people are comfortable with treating patients that are still PCR positive with chemotherapy or immunotherapy, even if it was potentially safe. I think having that PCR positivity is troublesome. But we also know that patients are remaining positive even for months, and even in the asymptomatic phase. So there's many unanswered questions there. I'll turn it over to Dr. Horn to comment further on that.
Do you want to add any comments, Dr. Horn?
No, the only thing to add is there have been reports of patients who are still PCR positive, who are asymptomatic after being symptomatic, who then get treatment, and then their COVID-19 symptoms flare and they end up hospitalized. So, it definitely depends on what therapy you're going to administer. Particularly, these reports were in patients who are given chemotherapy. We have an amazing at-home monitoring for mildly symptomatic patients here. Our institution very quickly put together a web platform. Patients are called by physicians and nurse practitioners daily at home. There's a quick transition if they become more symptomatic that they're admitted to the hospital. This is both cancer and non-cancer patients. But we also recognize that here in Tennessee, we have not had the major surges that some of the other countries and states have had, and so managing this has been a more manageable endeavor for our institution.
Yes. So let's ask specific questions about your study because you mentioned about systemic therapy and so on. What about the other disciplines? What about the impact on radiation therapy, surgery, and so on? Do we have any data ready or being collected so we know how the other discipline will be impacted in managing lung cancer or the thoracic malignancy, not just lung cancer?
Yeah, so, initial data from Asia suggested that lung cancer patients who have surgery and then develop COVID-19 are at increased risk for mortality. But for many of those patients from those Asian series, they appear to develop COVID-19 post-operatively, potentially in the hospital. We don't have the clear data on those patients. Many patients in the U.S. And in Europe are getting screened for COVID-19 prior to a surgery. So that may reduce that risk of mortality. We are collecting the surgical data, and I think we're going to have some data on asymptomatic patients who are going for surgery, but at many institutions, ours included, if a patient is asymptomatic but COVID positive, they are not having surgery. Their surgery is being delayed for 2 weeks. We also are collecting data on radiation therapy. It's being led by a couple of investigators within our consortium, and they're looking not only at where the radiation therapy was given, so was it given to the chest versus bone versus other. They're also looking at the doses of radiation therapy that were administered, so I think we'll have more information. As far as tyrosine kinase inhibitors, which are increasingly being used in lung cancer, 2 got FDA approved last month for another 2 mutations. Those patients appear to be at lower risk. There are some confounding factors, and those are also our younger patients. There are never smokers, there are female patients, and those are demographics that appear to be related to decreased risk of COVID mortality. Those are also patients that have less interaction with the healthcare system because they come in every 3 months with a CT scan. So I think we're going to get more information. We're also looking at, does the type of chemotherapy matter? Does it matter if it's combined chemo and checkpoint inhibitor therapy? Or more patients dropping chemotherapy and staying just on the checkpoint inhibitor. But the data that we have so far is primarily on the systemic therapy, and we'll get more data on surgery and radiation as more patients are included.
Well, thank you very much. We are out of time, but I just have to pass an information question that is interesting, that I wonder if the gender difference will be different in low resources country. Now we know the male are doing worse, but, one of our audience asked, do we know if it's different in the low resources countries? So maybe it's something worth looking at. But because we run out of time, I would like first of all to thank you very much for a very nice presentation and discussion. I'd like to thank our audience, and I would turn the mic to Doug to conclude the webinar. Thank you all. Thank you very much.
Great. Well, thank you for such a great discussion. I'd just like to echo Dr. Jazieh, your comments. Thank you to Dr. Horn, Dr. Warner, Dr. Schilsky for your excellent presentations. Thanks to all of you for your excellent questions. I do think that final point on the resource-limited settings, excellent topic for a future webinar. And looking ahead to future webinars, just as a reminder, mark on your calendars. The next webinar will be on July 28th, and we hope all of you will be able to join us for that webinar. As well, we encourage you to submit topics that you'd suggest for future webinars on a WebEx survey. After this webinar concludes, you will receive a link to that survey. Once again, recordings will be posted to the webinar series page, so please feel free, and we encourage you to share those recordings with your colleagues. And if you would like to have a certificate of attendance for the webinar, just email international@asco.org. You see the email address there on your slide. And just once again, thank you to all of the faculty, to Dr. Jazieh for moderating the session so well, and to all of you for joining us today. Thank you again, and please stay safe.